Okay, thank you very much, Nijasri, and good afternoon to everyone. So glad to be here, and also I'm happy that you're around. Before I start, may I know how many among you are doing TCD or any of this ultrasound? So one, two, three, four, four. Okay. So the rest are neophytes. First time to see a machine, first time to hear a lecture like this. Okay, that's all right. So we would know on what levels you should go in this lecture that we're going to do. Okay, what I'm going to present to you is, the picture that I've shown to you earlier, the photographs shown are all being done in the laboratory, right? And you have all the convenience there. You're happy, you're smiling, then your picture will be taken. But the moment you're in the ICU, hell get loose, no? You don't know what's going on. People running around, okay? And every now and then you will be bumped into while you're doing your transcranial Doppler, right? And as I mentioned earlier, just a little bit movement of your fingers, you will lose all those waveforms. Plus the fact that you're under stress because of all these artifacts that you see while doing your transcranial Doppler. All right. So in spite of that, we still have different conditions wherein our transcranial Doppler will be able to be of help to us. Firstly, in the diagnosis and monitoring of cerebral artery vasospasm, and then we would like to detect if there is intracranial pressure, and probably inversely or indirectly would be able to determine the intracranial pressure. And thirdly, it might help us in the diagnosis of cerebral circulatory arrest. I'm not saying the diagnosis of brain death, probably collaborating diagnosis of brain death, but what is important is for you to show that indeed there's tumor flow going on in the brain. Right? And fourthly, in acute ischemic stroke, you might be able to monitor recanalization during sonothrombolysis, and probably microembolisms can be also detected. And lastly, which is a little bit difficult because you might do some special tests, especially in the neuro ICU, would be cerebral autoregulation and vasomotor activity. So for this lecture, I'm just going to talk about the three most important things for me that I usually do in the neuro ICU. That is for vasospasm. Second is I would like to know whether there is an increasing intracranial pressure that would be able to help me in the management of my patient. But right now, this is what we're doing. We just don't give monitor every now and then. We do monitoring. We do monitor the intracranial pressure. The pressure goes up, we push mannitol, and then we wait again, monitor the intracranial pressure. And thirdly, we would like to complement the clinical diagnosis whether this patient is really dead or not by doing our transcranial Doppler. All right, you're all aware of a clinical history of a patient who suddenly developed a thunderclap headaches, right? And then severe headaches, and then we really don't know whether he lost consciousness or not, but we presume that there was loss of consciousness. And upon regaining consciousness, he started to be conversant, but still complaining of severe headaches. You did your examination, indeed, there was neck rigidity. So you give a diagnosis. This is subarachnoid hemorrhage. Okay, so you did all your studies, but unfortunately, we still have to wait for our radiology to do contrast study to be able to demonstrate the aneurysm. So for a while, we were still waiting and then monitoring the patient. And then after about 2 or 3 days, while waiting for our radiology, which happens in our country, most probably in some uh, well-developed country, this doesn't happen because right there and there they might do radiology or radiological diagnosis, but in some part of my country, it really takes some time for the radiology to be done or the neuroimaging to be done. So while waiting for that radiological test to be done, patient starts to deteriorate. So it's hard to arouse, okay? And probably you might see some weakness on one side of the body. And you start to wonder whether what happened to this patient. Did he ruptured? Was there a rupture of the aneurysm? Or is he developing vasospasm? So these are the two things that can happen after an acute subarachnoid hemorrhage. Okay, so a vasospasm after subarachnoid hemorrhage occur in almost about 70% of patients who had subarachnoid hemorrhage. It may be symptomatic or asymptomatic, and half of them, probably 20 to 40%, will become symptomatic. Become symptomatic in the sense that they may develop a focal neurologic deficit, they may have hemiparesis, okay? And probably we could attribute this to the development of delayed cerebral ischemia. So there was, because of the severe vasospasm, there might be a transient or it might be an ischemia going on in that particular area being supplied by that blood vessel. And then there are instances that this is what we may say the asymptomatic vasospasm. So this is what is really important for us to be able to determine whether this particular patient is going into asymptomatic vasospasm, which later on will become symptomatic. And this is where the role of our transcranial Doppler is very, very important. So from the time what we do in my center, from the time we see the patient or referred patient to us because of subarachnoid hemorrhage, we start doing monitoring. Even on day 1, day 2, day 3, although we know that vasospasm will happen probably after the 3rd day of the subarachnoid hemorrhage and will peak on the 5th day, but we start doing our monitoring for vasospasm. And we find that transcranial Doppler as more convenient for us rather than the TCCD, because you have a very big machine with TCCD, unlike your transcranial or TCD. It's just a small machine, and then you can bring it around the ICU, and you can push everybody just for you to be able to stand there, and you will not be disturbed by people in the ICU. So it's inexpensive. The machine is not really that expensive. It's real time, and you can do it every hour, every 2 hours, every 3 hours if you really want to monitor this patient. And it's non-invasive, so it can be repeated anytime you want. All right. Now, what would be our guide whether this patient will develop vasospasm or not? We look at our radiology, right? We look at our CT scan. Because our CT scan can be graded by means of a Fisher graded scale, or the grading scale by Fisher. The original one that the Fisher score, and then subsequently it was modified, but indeed almost close to each other, right? The Fisher and the modified Fisher also graded from 0 up to about 4. So what is important this? If you would look at the grading, you will see that the higher the grade they are, which means from probably from 1, maybe 1, 3, 5, and then up until 4, the chances for them to develop vasospasm is almost about 30% or more, okay? Which means that about 1 out of 4 of those patients will develop vasospasm. So indeed, you have to watch with this patient. So just by looking at the radiology or the CT scan, the plain CT scan of this patient, you might predict that this patient will go into vasospasm. So therefore, if you have a higher grade in terms of your Fisher grading, the closer the monitoring should be. So probably that's how we would be guided by this Fisher scale. So these are the radiological features that you would see. Ram, how did you do this? Okay, it's there. Thank you. So you can see the amount of the subarachnoid hemorrhage. Okay, so therefore it depends on the amount of the subarachnoid hemorrhage. The more blood you have in the subarachnoid space secondary due to ruptured aneurysm, the higher will be the predictive value that they will develop vasospasm. Okay, so now what is important if you see do your transcranial Doppler is to be able to differentiate whether you're dealing with hyperemia or vasospasm, because both of them can cause an increase in your mean flow velocity. when you develop subarachnoid hemorrhage, there is always a tendency for the blood flow to increase into your brain, right? Because it needs more blood after that subarachnoid hemorrhage. But at the same time, that blood can cause the blood vessel to go into vasospasm. And both of them, if you do your transcranial Doppler, will have the same value, or you can see that they're all both elevated, right? Both of them are elevated, but if you look at the waveform, from the waveform, you might be able to differentiate whether this is really hyperemia or a vasospasm. In hyperemia, probably in this picture, you would see that they're peak, and even the diastolic velocity are also peak. But in vasospasm, you can still see the maintained waveform. The morphology is still maintained, but you can see that the velocity is already increased. Okay, and if you take the Lindengaard ratio, which probably we're going to talk about later on, you will see that in vasospasm, you have an increase in Lindengaard ratio. If it is hyperemia, there's no increase in the Lindengaard ratio, which is the ratio between the velocity of your MCA and your extracranial ICA. So we'll go into that later on. Okay, now, when do you say that there's an increase in the mean flow velocity of somebody who had a vasospasm? In hyperemia, you would see that the mean flow velocity may be a little bit less than 120, and then the Lindengaard ratio is always less than 3. But if it's really a severe vasospasm, you would see that the velocity goes up, okay? It goes up, and at the same time, your mean flow velocity, your Lindengaard ratio will now start to increase. So an increase in mean flow velocity of your MCA, if you're insonating the MCA, and then you take the insonation of your extracranial ICA, and if your Lindengaard ratio is quite high, which I'm going to show you later on how we do this, then you may say that confidently that indeed this is a vasospasm rather than a simple hyperemia. All right. So when we monitor for the vasospasm, we monitor, of course, for the ratio, which means I'm talking about earlier, the velocity of your MCA and the velocity of your extracranial ICA. Okay? Now, if there's an increased velocity in your MCA because of the vasospasm, okay, blood vessel in the MCA goes into spasm, you expect that the mean flow velocity there will go up. But if you take your ICA, which is not into spasm, you might be able to get a normal or might even low normal velocity for your ICA. Therefore, if you take the ratio, imagine that flow velocity here is more than 3 times than the velocity in your ICA. Therefore, you can say that the velocity, the ratio is more than 3. So your Lindengaard ratio is more than 3, which may be indicative already of an early vasospasm. So you can also do this in the posterior circulation if you feel that the vasospasm is occurring in the posterior circulation. You can do the modified Lindengaard by taking the basilar artery, the mean flow velocity of the basilar artery, and then compare it with the extracranial vertebral artery. Okay, and then you will be able to get the Lindengaard ratio. This is how we do it. So we take this is a normal one. So the MCA here is about 87.6, and we take the mean flow velocity of ICA, extracranial ICA, which is 2.5. So the ratio is not really, the velocity of your extracranial is about 34, so the ratio is just about 2. But in cases of vasospasm, there is an increase in mean flow velocity of your MCA at about 164, but your ICA is only 31.3. So the ratio is really that much. So you divide the MCA by the ICA, mean flow velocity, then you get the Lindengaard ratio. Okay? Therefore, that ratio is just the ratio velocity of your MCA and then the velocity of your ICA. And then you get the ratio, which is we call the Lindengaard ratio. Now, the MCA, we have the monitoring, so we follow this kind of monitoring. So we mild vasospasm is this much, 120 to 149 with that Lindegaard, and then so on with severe, we go more than 6 in the Lindegaard, and then more than 200 in mean flow velocity. Now, what is important here is really not the absolute value, okay? Please be reminded of that. It's not actually the absolute value, but the trend, okay? The trend of the increase in the velocity. Even let's say, for instance, you get 100 for MCA in the 8 o'clock in the morning, but when you repeated your TCD at about 5 o'clock in the afternoon, it doubles. That's already an alarm, okay? It's probably an indication that indeed this patient may go into severe vasospasm anyway. Imagine it doubles the velocity in about 12 hours. So look at the trends, right? So look at the trends of this velocity. So aside from just monitoring vasospasm, what we did is we used this transcranial Doppler in our study. We would like to know whether cilostazol would be effective in preventing vasospasm amongst patients with subarachnoid hemorrhage. So we did a study. We compared patients receiving nimodipine alone and then patients receiving nimodipine and cilostazol. We know that cilostazol is a vasodilator, and hopefully it might be able to dilate those blood vessels and be able to relieve the vasospasm. So this is how we did the study. We get a group 1 or group patients with nimodipine alone, and then another group of patients with nimodipine and cilostazol. And what we have shown is that there's a 62% risk reduction in the development of vasospasm if they receive cilostazol. So since then, we started giving patients cilostazol in our center after subarachnoid hemorrhage. And right now it's an ongoing study, and we would now want to compare 200 and 300 milligrams of cilostazol, and it's still an ongoing study, and hopefully we'll be able to finish this before the end of the year. Right now, we have already collected about 40 patients, so probably before we hit 100, we'll be able to report this. Now, about intracranial pressure, what do we get out of this transcranial Doppler in trying to determine the intracranial pressure? So this is a case of a 61-year-old male who presented to us with decreased level of sensorium. It was stuporous with right-sided hemiparesis, a blood pressure of 200 over 140, and neuroimaging was done, and there was a massive intracerebral hemorrhage, probably secondary to hypertension. So we label this as a primary ICH, or intracerebral hemorrhage secondary to hypertension. And then we try to assess whether the pressure is really building up on this patient. So we monitor the transcranial Doppler. And the intracranial pressure is determined by these 3 factors or 3 volumes: the volume of your brain, the blood, the CSF, and also the venous outflow. Okay, so you take all these different volumes, and that will give you the cumulative effect, cumulative volumes, and then that will give you the intracranial pressure. So any change in any of these volumes probably will also affect the intracranial pressure. At the same time, when you're doing transcranial Doppler, we also analyze the waveform. Okay, the waveform is very important. That as the pressure intracranially goes up, okay, because of whatever reasons that would change these different physiologic factors, or you have an increasing mass intracranially, the first index that would suffer or that be affected will be your diastolic flow. Okay? So your systolic flow will remain there, but your diastolic flow starts to go down as the intracranial pressure goes up. So you would see in this figure that your systole is still there, but your diastole is already down. Okay, so if you take your pulsatility index that was given to us earlier by Nijasri, you would see that the pulsatility index starts to go up. Okay, from a normal of 0.6, and then because of the pressure increasing intracranially, you get an IPI of intracranial pressure or other pulsatility index of 1.6. Okay, and this is probably if you really would like to look and calculate for the pulsatility index, this is how you'll be able to get it. And there was this study that was done taking taking a group of patients with known intracranial pressure, and these are patients with TB meningitis. So they try to associate or try to determine the relationship between the transcranial Doppler pulsatility index and then doing a lumbar puncture and determining by manometer the ICP, the intracranial pressure. Okay? So intracranial pressure was determined by doing a lumbar puncture and at the same time doing a transcranial Doppler and trying to associate the level of the manometer pressure and then the transcranial Doppler level as far as your pulsatility index is concerned. And what they have shown, which is quite significant, is that at a level of 1.5, meaning the pulsatility index of 1.5, which further, if you have a pulsatility index of 1.26, that could predictably say that your pressure is more than 20 centimeters water or 200 millimeters water. Okay, so that's probably a good way of trying to determine intracranial pressure non-invasively, just doing a transcranial Doppler. Second is what we call as an ancillary procedure in the diagnosis of brain death. So this is a 24-year-old female with decreased sensorium, came comatose, unresponsive pupils, and he arrested on day 6, and CPR was done and was revived and deemed a poor surgical candidate. And then we were requested to do transcranial Doppler. So up until this time, the consensus on the diagnosis of brain death still follows the clinical and lab tests, okay? The clinical criteria, so I'm not going to that. The issue regarding brain death came in because of the organ donor, right? When can we harvest the organ for transplantation? There are other supplementary tests that can be done. If you want to determine the neuronal function, you do your EEG, your Baer, or your somatosensory evoked potentials. If you're interested in the blood flow, you can do your DSA, your CTA, MRA, of course, your transcranial Doppler. And your transcranial Doppler will just give you will be able to determine to you whether there's already a circulatory arrest. Okay, so how do we do this? Just a simple way that when we do the transcranial Doppler, and we document arterial blood pressure, and then after which we start examining the MCA, and we have the opportunity to examine the posterior circulation, the basilar artery, it's much better, and then we look for different reverse, okay, as I've said, that there is already an increasing pressure, all right? And then if the blood flow starts to decrease, or the cerebral blood flow starts to decrease, we will see different types of blood flow. One is the reverse minimal end-diastolic flow, which means that in essence, blood is no longer flowing through the artery, okay? So your Doppler will be able to detect the forward flow, so you get a systolic flow, but at the same time, since it's no longer moving forward, it goes back. And that backflow can also be detected by your transcranial Doppler. So we'll see now that your systole and diastole is just going to and fro, to and fro. So you got a reverberating flow. And probably that would now be an indication that there's no more net flow going on in the cerebral blood vessels. So here's a baseline transcranial Doppler, and then after day 6, you will see the changes on your transcranial Doppler in this figure, or in this waveform. You can just see a short systolic flow, but in this figure, you will now see the systolic and then diastolic flow, which means that there's a to and fro movement of your cerebral blood flow. TCD carries about 90% in sensitivity and about 98% also in the specificity. Although it may yield a false positive results because some residual parenchymal flow, although the net flow is no longer enough to sustain life or the function of the brain, but still there may be some flow going on in the brain. And that could still be picked up by your transcranial Doppler. So TCD is reliable, it is reproducible, it's a portable tool, so you can bring it around from the ward to the ER to the emergency room. And then, although we got to be cautious in the interpretation of TCD, and the findings should be interpreted in the context of your clinical findings and your TCD parameters. So with that, I would like to end this talk, and thank you very much for your kind attention.